Well, good afternoon to everybody, and thank you guys, everybody, for being here and participating as we celebrate our hand research team and also our graduating fellow. And it's not Back to the Future, like I was pointing out, it's 2024, so that's on me. So that's what happens when you don't have your reading glasses and you're putting numbers in. But thank you. We're excited to present all the work that's part of the work that's been here. We've selected some studies to present, and then we'll have Michaela present her work for the year and her experience with us. And just welcome to her family to Roanoke. Thank you for sharing her this year as well as Landon. And it's definitely been a great year. And to our faculty for all the work, I do really, this is a team effort, and for the success of each year of our fellowship, now we're into our fifth one. It's all of what you guys contribute. So thank you. And then to our research fellows. So we're excited. And well, I'll do a little bit of a kind of back story. I mean, we're started our fellowship in 2019, and we've progressed in our research department, especially, spearheaded by Dr. Appel. And one of the things we've co-authored, and now these numbers have changed in the past 3 months, but about 21, 22 articles, performed 12 podium presentations, 5 video presentations, and that's not including our channel that we currently have, that we have our didactics that we base that. And we've had 14 invited lectures at regional and national meetings and 5 poster presentations. So definitely this is has been growing, and it will continue to grow. And we believe that in 5 to 7 years, we'll definitely have a pretty strong footprint in the hand surgery aspect from Virginia Tech Carilion. And just a few, we have each of our fellows have had publications. So our fellows definitely have been very productive, and it does basically this demonstrates and exemplifies the work of our research team, our research committee, our, you know, directed with Peter and our associate program director, Dr. Vaughn, and all our faculty. But this is the work that they're able to do in a short amount of time and really answer clinical questions. Tonight and today, we're also celebrating our graduating fellow, Dr. McCarthy, and it's been a great year. We're definitely sad that you're finishing, but excited for all the good things to come. And she'll be experiencing, she'll be sharing some of her experiences. And now, I do also like to thank Dr. Natalie Vaughn, my associate program director, for all her assistance. And then I'll have Dr. Apel to come and introduce the selected studies that we're planning on presenting. Okay.
So thank you all for being here. We've got some of the folks in our lab that are going to present. For those of you that are not familiar, our lab has a variety of individuals. We've got medical students like Musafa here, some of whom go into orthopedic surgery, some who do not. We've got undergrad, college graduates. We've got Cam Novakova and Mehmet Klink, who are wanting to go into medical school. We've got medical school graduates, Alex Garcia, Devin Picas, Nick Peterman, who want to do orthopedics. So we've got folks at all levels of training who participate in our lab and who participate in research, both for the advancement and the knowledge acquisition, as well as the mentorship and career advancement. So with that, today we want to give each of them a chance to present some of the research. And we'll open the floor up for questions from the staff, from the faculty, and from anybody else who wants to ask questions. So with that, we'll have Musafa come down first. So Musafa is a third-year medical student, and she was assigned to orthopedics for her primary research project, and she's going to present on what she found. Actually, this is a side project of hers, excuse me, her main project is a different one. So this is a side project of hers. So go ahead. Thank you.
Thank you, Dr. April. The environmental impact one. Uh, you may have passed it. Yes. That's okay. Thank you. Hi everyone. Some familiar faces, some unfamiliar faces, but I'm Mustafa. I'm a third year, rising fourth year medical student here at VTC. Um, I am working with Dr. Apel and many other team members on this project and a few other projects. But I wanted to talk to you about this exciting study that we completed over the last year. So the first of all, I'm gonna figure out if I can. Oh, nice. So the study is titled Environmental Impact of Overtreatment of Buccal Fractures. Buccal fractures, as you know, are one of the most common type of pediatric orthopedic um, fractures that we see in pediatric orthopedics world. They usually heal uneventfully within 3 to 4 weeks with simple management. Um, Extensive evidence exists over the years that tells you that we don't need to put any rigid casting or have multiple x-rays or follow-up visits to treat these types of fractures. So using that research and literature that exists, we've coined the term best buccal evidence-based strategic management. In this, there is only a single provider visit, a removable wrist or bandage provided to the family, and then no additional follow-up x-rays or visits for treatment of that fracture. So where is the gap in knowledge? This is not a new news that conservative management is good for buccal fracture treatment. It has better functional outcomes. Even the first study that came and that proved that there were better functional outcomes with conservative management versus management with rigid casting came out in 2006. So it's not a new concept, it's not a new news. Despite that, only 29% of fellowship trained pediatric orthopedic surgeons use removable splints. So, we have studies. My primary study looks at, feasibility of implementation at a institution level of a conservative management, or the time that children miss from school or the parents miss from school because of having to do rigid casting and what that may lead to. However, no study exists in the literature that talks about environmental impact. So this study that I'm going to talk about utilized a retrospective review for our institution's buccal fractures with geospatial analysis to estimate the national environmental impact of buccal fracture overtreatment. So for our methods, we included children who were between 3 and 17 years old who were diagnosed with distal radius buccal fractures at our institution. From 2018 to 22. So we used diagnosis codes to pull those charts out of EMR, and there were 1,050 charts. We then did a manual review of each chart by one of our team members, and we looked at if they met all the inclusion criteria and ensured that they did not meet any of the exclusion criteria. And then we collected data. On the data that we collected was method of treatment. Did they have a rigid cast or did they have a brace? Did they have follow-up x-rays or not? Did they did they have to come multiple times to see a specialist or did they only come once? We also collected zip codes. So those zip codes were used, home zip codes of patients. They were used to travel the distance from their home to the nearest orthopedic specialist. So that helped us identify carbon dioxide emissions. And those carbon dioxide emissions, we use this 411 grams per mile based on this estimate from Environmental Protection Agency, which was published in 2023. So using this number, we calculated how much carbon dioxide was emitted from additional visits. We also estimated cast waste, and basically we just collected 12 casts, short casts at ION, and weighed them all on a scale of, and then measured an average weight for those casts. So those are the methods. So for our results, here I'm illustrating a bar graph. On the x-axis, you have a type of treatment, either it's a brace or a rigid cast. And then on the y-axis, you have average number of additional visits. And by additional visits, I am not including that initial visit to the specialist that everybody had to do. Mostly everybody sees a specialist at least once, so that was excluded. And the numbers at the bottom, N75 and N357, that's not the entirety of the chart. These are only patients who had additional visits in both of the groups. So as you can see, rigid casting, the people in rigid casting had statistically significant, more visits than brace group. So that tells you that they were traveling more distances than the people who were in the brace group. Similarly, I talked about the geospatial analysis that we did to calculate the incidence. So we calculated incidence based on a zip code. So at our facility, we had a specific number of buccal fractures in one zip code. And then we used US Census to see how much of the pediatric population was in that zip code. And then we found an incidence, which was non-adjusted. And then we adjusted it using how many other pediatric orthopedic specialists are in that area. So we can talk more about that math afterwards if you'd like, but using that model, we calculated that there were 66,495 buccal fractures in the US every year. And of those, 62% were overtreated. And that's what you're seeing in this pie chart. So in conclusion, each year, overtreatment of pediatric buccal fractures generates 9.4 tons of classed waste and 405 tons of carbon dioxide from patient travels. So, it is a retrospective study. We do have limitations, especially firstly, the national incidence that we measured. There is an assumption that the buccal fracture incidence is conserved throughout the US, which may not be true. Travel distance was also based on nearest orthopedic specialist, but we also know that there are other primary care physicians or pediatricians who treat them without sending these fractures to orthopedic specialists. So there may be times that distance was overestimated. We used the EPA estimate for grams of carbon dioxide produced, and that could potentially, not every vehicle is the same, so it's a little simplification. And then lastly, buccal fracture incidence was calculated over a time period, as we all know, where there was COVID-19 pandemic, and that incidence may not reflect what may happen in future or what happened before. Well, we will have another study talking about how the shift happened, but just keep in mind that those years may have impacted those numbers a little bit. Despite these limitations, we believe that this is a valuable addition to literature because, we've always, I've shown you this value-based model multiple times for my primary study, and that we want to maximize value by increasing quality and reducing cost. And in that cost, we are more likely, and it's easier to talk about monetary expenses to the patients in terms of work that they miss from, like the time that they miss from work, or children missing school, or providers spending time on these patients versus somewhere else where they're more needed. However, we don't talk that much about environmental impact. And because we don't talk about it that much, there aren't that many studies that quantify carbon footprint. And buccal fractures being one of the most common type of fracture, it's imperative that we talk about carbon footprint because they lead to a number of visits, and we have quantified for the first time how much that carbon footprint is, and it's considerable. So hopefully this can be another factor that we incorporate in this model, and that will help drive change, not just at the provider level, but also at the patient level. So thank you.
We have any questions for Mustafa?
Efforts are being made to cut down on waste, and it is significant. And we as orthopedic surgeons, field of surgery with medicine, lead the list for generating a lot of trash. And so wherever we can cut back on waste, it's impactful, significant. So I think this is an important study. It just highlights how little nibbles on the problem can create a big solution. So thank you.
Thank you. Dr. Karolinko. Well, yeah, to that's a great transition to Mehmet. Why don't you come down and tell us how the COVID-19 pandemic affected buccal fracture treatment? Huh?
Just move forward with this. Hello, my name is Mehmet Kılınç. I'm a research assistant here in Dr. Apel's lab, and I'll be presenting impact of the COVID-19 pandemic on buccal fracture treatment. PI for the study was Dr. Apel. So, I mean, Mosaf already went through a lot of the background for us. Buccal fractures are common. They comprise about 27% of all pediatric fractures. Like Mosafa said, one of our other studies from the department looked at estimating the national incidence and found it to be about 66,500 buccal fractures annually. A lot of prior studies have looked at these. You know, Mosafa mentioned the 2006 randomized controlled trial. There was another one in 2022. So there's plenty of evidence, demonstrating the effectiveness of these conservative treatment algorithms. And like Mosafa said, also, we coined the term buccal evidence-based strategic treatment, or BEST, which is just a single provider visit, no follow-up, imaging or visits, and removable wrist brace use for 4 to 6 weeks, like Mosafa mentioned. And so during the COVID-19 pandemic, many providers reduced the number of in-person healthcare activities. Obviously, patients and healthcare workers all wanted to kind of isolate, stay away from each other to reduce the risk of transmission. And so we wanted to see if a secondary effect of this was an increased utilization of BEST for buccal fracture management, given the low contact interests of everybody at the time. So methods, Musaf already went through this as well, so it doesn't leave me much to talk about. Retrospective chart review was conducted. A subset analysis was conducted between 2020 and 2021. In 2022, ICD code was used to isolate patients. Radiographs were reviewed. All non-buccal fractures were excluded, including concomitant fractures, maybe a green stick fracture, anything that really did not classify as a standalone buccal fracture. And the adherence to best practices were extensively reviewed. This is a small little flow chart. We ended up with 602 that met our criteria. 226 were given a removable wrist brace. 376 were given a rigid cast, and 151 of the removable wrist brace group were considered to be treated using the BEST protocol. So this is a nice bar graph that we created. You can see the y-axis shows the best utilization percentage, and the x-axis shows the 5 years that were studied. And then the red line indicates the onset of the COVID-19 pandemic. in the 2 years leading up to the COVID-19 pandemic, there was approximately an 11% adherence to best practices, and that number significantly increased in 2020 to about 41% and was later sustained in the 2 years that followed for a blended adherence rate of about 37%. Analysis was done using a chi-squared, and the p-value was less than 0.001. I forgot to include that here. And this is just essentially the same data organized into different, using different provider credentials. We have fellowship trained pediatric orthopedic surgeons in black, non-pediatric fellowship trained surgeons in dark gray, and non-physicians, including nurse practitioners and physician assistants, in light gray. What I'll note here is that in the pre-pandemic years of 2018 and 2019, there was approximately a 30% to 34% adherence rate to, these guidelines, the best guidelines or the best protocol. And I think, what Dr. Kirilenko was referencing earlier was that 29 to 30%. And so our numbers are comparable to that. And after the pandemic, we saw that rise to about 66% in pediatric orthopedic surgeons. And so that's one of the key findings of our study, and it helps validate our study because in 2012, when the initial POSNA survey was published, looking at best utilization rates, again, it was found to have about 29.1% of all pediatric fellowship trained orthopedic surgeons following those guidelines. And then in 2020, another survey was published, another POSNA survey was published in June 2020 that said that that number had increased to about 69%. And so they concluded that over the 8-year period between those two studies, that it was a gradual increase and not a sudden or abrupt one. But given our data looks at, the 2018 and 2019 pre-pandemic years as well, and those numbers are comparable to one another, we conclude that it was actually more of a stepwise change, a more abrupt change after the onset of the COVID-19 pandemic, and not a gradual one. So we conclude that the COVID-19 pandemic did lead to a significant increase in best practice utilization for buccal fracture management across all provider types. The reasons for this, because it is a chart review, cannot be, definitively ascertained. But, it's important to note that the low contact interests of the time likely aided in this. This study demonstrates that motivation plays a substantial role in the management of buccal fractures, and advocacy to implement any evidence-based medicine must first understand that there are certain external factors that influence medical decision making, particularly when it comes to pediatric fractures. This study is obviously limited by its observational nature. It is a chart review. We only have access to what is provided on patient charts, and it doesn't take into account the nuances of medical decision making and all of the conversations with the parents. And so one more limitation is that the observed period ended 3 years into the pandemic, so it's uncertain whether this effect will be sustained in the years following. So these are my references. Thank you.
Thank you, Mehmet. Any questions for Mehmet? Dr. Capito. So there's been a body of literature that has been evolving probably since 2006 and beyond that's demonstrated that the results are similar. even better with bracing. There have been position statements that have come out between the American Academy of Pediatrics and POSNA regarding these recommendations: removable bracing, single provider visit, and no follow-up X-rays. So we just simply lumped all those together and gave it a new moniker. Yeah, it's interesting. There's clinical practice guidelines for distal radiuses, for femur fractures. And one of the things that's interesting is even in, pediatric orthopedics, there have been a handful of studies that have looked at, even though these guidelines were published and agreed upon, what adherence to them is. And adherence rates are sometimes low, 30% for other conditions. I mean, ours was at least in the 60s. When I say ours, I mean we pediatric orthopedic surgeons. And so there's a lot of interest, in the health system, health science implementation research space about why providers don't follow those recommendations. There's even studies that look at, you ask them a test question about what would you do in this circumstance, and then you look at their practices and there's a delta, sometimes 30, 40% adherence. And so if we're going to change practices, or if we just want practices to adhere to our guidelines that are established by science, those of us that are in this space are trying to understand, like, why don't people follow guidelines? Like, what are the reasons? And so, Dr. K brings up one, but there are certainly others. There's other reasons. There's financial motivations. There's a belief that surgery is better than non-surgery. There's parental pressure, societal pressure. One of the things that we're trying to introduce by looking at environmental factors is introduce another factor to consider. It's not just cost, outcome, convenience, but also, your global impact. We're trying to add that fourth dimension of decision making. So it's a good question. It's an unsolved one. Mm-hmm. Yeah.
Basically, if you're not following that, you're not fully steering.
Yeah.
That made me wake up.
Yeah, we have clinical practice guidelines that the Academy has, put out for various conditions: carpal tunnel, distal radius fractures, pediatric femur fractures. I'm sure there's others I can't think of right now. But we have problems in orthopedic surgery with adhering to those guidelines even. I guess the plastic surgeons are better behaved. Dr. Vaughn. Mm-hmm. Yeah, I'll tell you something depressing. Unfortunately, they don't work. So this has been examined in pediatric orthopedics for conditions like intoeing, outtoeing, tiptoeing, and some of those other conditions that generate inappropriate referrals where they've gone out, they've tried to educate the primary care providers, and it just doesn't work. And so we wish it would work, but the problem is that those outreach programs are just, they don't lead to sustainable changes in behavior. Part of what we found interesting about the COVID-19 pandemic, it was overnight, right? Behavior changed overnight. And so, I don't know. If somebody's got an answer to this question, I'm all ears, because I don't really know what the factors are that'll motivate and change behavior. But we think education is probably not good enough. All right, who's next? Thank you, Mehmet. Great job. So Cam Novikova is our eighth participant in what we call our Scribe Scholar program. For those of you not familiar with it, this is designed for students that have graduated from college that want both a combined research and clinical experience. And so Cam scribes with me in clinic. She sees patients, she gets that clinical exposure, but she also participates in research. And so she's going to talk a little bit about a study that she's been working on entitled Patient-Directed Care After Carpal Tunnel Release Using Video Integration and Digital Education After Operations. Video.
Hi, everyone. As Dr. Apel said, my name is Camden Novikova, and I'm going to be presenting on our carpal tunnel video study. Just to give you all a bit of background, carpal tunnel release is a fairly common procedure. It's performed around 600,000 times per year. This is typically indicated when a patient has failed non-operative management, typically bracing or corticosteroid injections. And it has a very, very low complication rate, so around 1.2 to 2.1%. Because of this low complication rate, there has been a focus on finding ways to mitigate resource and utilization, not just for carpal tunnel, but for other, orthopedic procedures, such as trigger finger CMC arthroplasty through telemedicine. Reasons for this is it's easily accessible. Around 85% of Americans have access to a smart device at home capable of playing video content, and patients love it. They like not having to leave the comfort of their own home. The difficulty is that it can be difficult to implement telehealth practices. It can, disrupt workflow, and it can be hard for patients to recognize that the lighting might be poor and their angle might not be the best to show the physician their actual problem. So this leads us to our research. Takes us to our research question. Are we capable of producing a non-interactive patient-directed post-operative care program? The reason we want it to be non-interactive is so that way patients don't have to worry about the lighting and the failures of telehealth, particularly for this, and compare it to the current standard of care. Would it be better? And our research aim would be to develop this and compare it with patient-reported outcomes, satisfaction measures, and resource utilization. So for this study, it is a prospective randomized control. Our control group had no deviation from the standard of care. They followed up at 2 and 6 weeks, as they were supposed to, whereas our experimental group, they did not follow up in the office. They were provided with 3 short videos that they could watch at any point in time on a phone, tablet, or a laptop. Every single patient received 4O monocryl sutures. This was so that way they didn't have to come back into the office to have the sutures removed. Additionally, our primary outcome measure was the PROMIS upper extremity. This allowed us to gauge the patient's function following carpal tunnel study. We also collected patient satisfaction surveys, which are ranked on a 1 to 5 Likert scale at 2 and 6 weeks, which is typically when patients would follow up in the clinic. We also performed a chart review at 3 months post-op, and we looked at MyChart messages, the distance that the patients have traveled, their total number of office visits, and any sort of wound complications, so surgical site infections or wound dehiscence. So in order for a patient to be eligible for this study, they had to be undergoing solely carpal tunnel release. They could not have a trigger finger, they could not be undergoing ganglion excision or deep wear veins release. They had to be fluent in English. They had to also have access to the internet and the capability to use a smart device. Patients that were not eligible were those that were undergoing revision procedures, those that had a positive workers' compensation status, as well as anyone who had an unstable mental health condition or a prior history of substance abuse. So in total, 132 patients have been enrolled. 52 have withdrawn, 1 withdrew voluntarily, 16 were withdrawn due to noncompliance, 5 patients failed screening, 2 of which were dermabond allergies that were not disclosed, and 3 of which had additional procedures after they were consented. And 30 patients were removed due to a protocol deviation. There are currently 80 patients enrolled, with our goal being 106. 78 have completed the study in its entirety, meaning they've completed the 2, 6, and 6-week surveys, as well as the 3-month chart review, and 2 have completed their 2-week surveys. So for our results, our primary outcome measure at this time is not significant. And this is demonstrated by a 95% confidence interval. We also have our secondary measure, the patient satisfaction questionnaire. These are the first 2 questions. Neither are significant. These are the 3rd and 4th questions. Keep in mind, this is the 2-week survey, patient satisfaction survey. These are significant. And these questions are: the method of your post-operative care was convenient, and if given the option, you would choose this method of post-operative care for future procedures. Again, the final 2 questions of the patient satisfaction questionnaire were not significant either, and these questions are: your symptoms have improved, and overall you are satisfied. Now we're getting into the 6-week data. Neither of these, again, the first and second questions were not significant. Keep in mind that all tests regarding significance were done with a Mann-Whitney Q. Again, the 3rd and 4th questions were not significant like the first. And then the final 2 questions were also not significant. Now for the data that was collected via the chart review. So this is the number of clinical and non-clinical messages sent through my chart. Overall, it's not significant, but the number of clinical messages was significant. The patients in the video group sent less. Now, for the total in-person visits, as expected, the in-person group had more, whereas the video group had less. There is an error on the PowerPoints. The p-value should not equal 0. That is incorrect. And for the wound complications, they were roughly the same for each group. So as this is an interim analysis, we can't really conclude any sort of information regarding our study. We have not yet reached significance, and we have not yet reached power. So we're going to continue enrollment until we reach 106 patients, most likely in August 2024. And I would like to acknowledge the Department of Hand Surgery, specifically the participating providers, Dr. Apel, Dr. Bravo, Dr. Doncha, and Dr. Vaughn.
Good job. Thanks, Cam. Any questions for Cam? Dr. Vaughn, Cam, come on back. You got to answer questions.
Yes. Personally, I think there's more content that's actually covered in the video than you can often get to in clinic. I know when working with Dr. Apel, sometimes we just pop in there. It's, hey, your wound looks good. And then we head on out. And sometimes the patients have more questions and they don't always listen. I'm sorry. I got to put you on the spot.
It's not quite like that.
Anyway, but no, and some of them, they may not feel comfortable asking those questions to the providers. And instead, they might feel comfortable getting it from a video format. Gonna mess with you a little bit. Sorry. So 15 of those were non-compliance with the research study, so they weren't responding to their surveys. And then one of them was clinical non-compliance. So this person was repeatedly asked to come back in to evaluate them for a surgical site infection, and they did not come back. So, oh, Unfortunately, there was no way for us to monitor that with the way our REDCap was set up. But in the future, if we would like to conduct additional studies like this, there are ways to actually check and see how many times patients click on a link. Mhm. Probably not. I'm going to be very going to be very honest with you. I called one of the patients and she told me directly that she would not be a good fit for the study because she does not know how to use a computer. Yeah. I agree.
All the videos on her phone, so she doesn't have to use a computer.
She also didn't have a smartphone.
Great, thanks. Nice work. So next, we have Dr. Pikas, who's one of our research fellows, who's going to talk about biomechanical failure of a bone model after removal of a 2.7 or a 3.5 millimeter plate.
Thank you, Dr. Apel. So this is a little bit of a switch from the previous 3 studies. It's quite a simple study, so we're going to have some fun with it and actually walk through it a little bit more than some of them. So for forearm fractures, they're very common fractures within the adult as well as the pediatric population. And for the treatment of them, typically an open reduction and internal fixation of those fractures. So what that means, open it up, you put a plate on it, screw both sides of the bone, and you let it heal. Following bone union, a lot of these patients, specifically pediatric patients, want that plate out. Whether that's for prominence or other complications, it all depends. Now, following removal, there's a difference in refracture rate for those individuals. When you remove that plate, the refracture rate is at a 6.3%, whereas if you leave it in, it's at a 2.1%. The thought of it, if you take that out, we don't have that plate protection, and there may be holes left in the bone where the screws were. So the gap in the knowledge is, does the size remaining of that screw hole affect the refracture rate? So to investigate this for our research question, is the mechanical strength of a bone model, which I'll explain what a bone model is, following removal of a 3.5 millimeter plate inferior to the mechanical strength of a bone model following removal of a 2.7 millimeter plate. So when I talk about a bone model, obviously there's not going to be a lot of radiuses and ulna sitting around that you can go put a plate on and test. So companies have come up with ways to basically grow structures that are as close to actual bone as we can get at this time. So big picture, what we did, took a bone model, you put a plate on, you took it off, and then you broke it. Basically what the study is. Now, a little bit more in depth, we use an Instron loading machine. And all that is, you take the bone model in the middle of it, it applies force until it breaks, and then it's going to measure at what force it took to break the bone model. So we had 34 bone models, 98 millimeters in length, 16 millimeters in diameter, and the cortical thickness was 3 millimeters. For the 2.7 millimeter plate, we had a Synthes 10-hole 2.7 millimeter locking compression plate. And then for the 3.5 millimeter, we had a Synthes 8-hole locking compression plate. For preparation, we took the bone model, took the plate, centered it, and then for the 2.7, there were 4 holes on each side of the plate that were then drilled. The plate was then put on. It was then removed. For the 3.5, the bone model had the plate centered on it, and then 3 holes on each side were placed, and then the whole construct was removed. For the axial testing, which is the top picture, it was placed in the Instron machine, and then it was crushed from the axial load, and then what that newtons of force that it took was measured. For the 3-point bending, which is the bottom picture, the bone model was placed in the Instron. The supports were set at 85 millimeters, and then once again, the force was applied until it broke. Now for the results of the axial compression plate, at the top you see the 2.7 millimeter, which the max to load failure was the 14,782. This was done 9 times. For the 3.5 millimeter group, it was at the 14,097, and again, done 9 times. Now to compare the difference between these, we decided to do a non-inferior analysis, which is the bottom graph. What this says, the x-axis is the max failure load, the y-axis is the 2.7 and the 3.5 millimeter plate. We took the 2.7 millimeter average, took 10% off of that. What that created was our threshold for our MCID, the minimal clinically important difference. And then we compared it to the 3.5 millimeter. Now, I was not familiar with this previous, so simply what it means is if the 3.5 millimeter group was on the left-hand side of that threshold, then we could say it was inferior to the 2.7 millimeter. So since it is on the right side, it is not inferior to the 2.7. Moving to the 3-point bending test. Once again, bottom right is the picture. The pressure was applied in the middle of the bone model until it was broke. Now, for the 2.7, it only took 2,228 on average to break it, and then the 3.5 was the 2,145. And we only had 34 models, so this one was only done 8 times each, whereas the axial was 9 times each. Now, to the inferior model again, non-inferior, excuse me, with the max load on the x-axis, and same thing, 2.7 versus the 3.5. And since the 3.5 is on the right-hand side of the MCID, our threshold, once again, it is not inferior to it. So our discussion with it, for our conclusion, we can say that the 3.5 millimeter cohort is non-inferior to the 2.7 millimeter cohort. But 2 things that we need to consider here with it, our thought was because it had larger holes, but because we wanted to mimic clinical practice, we used different numbers of holes for each of them, with 8 for the 2.7, with only 6 for 3.5. And then also with falls, typically outstretched hand, you're walking, you slip, you put your hand out, there's also going to be some sort of a torsional component to it as well. So it's not simply going to be an axial or a transverse load on it. And limitations with the bone models, of course, these are just replications of as close as we can get to what bone is, but as of right now, they're not actually perfect. And this hypothesis also came from differences in refracture rate, where we simply looked at the mechanical strength of the bone. We actually didn't look at any of the refracture rates. So conclusions is that surgeons should pick the plate and screw construct that they're going to use based on what they think is best for the fracture, and do not put any consideration into what they think could possibly be a difference in strength or refracture rate if they need to remove it. And finally, there's no meaningful difference in the biomechanical properties regarding bone model strength following the removal of 2.7 or a 3.5 millimeter plate and screw construct. Questions?
Great, thanks, Devin.
Thank you. I'm going to say up here.
Any questions for Devin? Dr. Capito.
As of right now, no. This was actually done in 2017, but we just never published it. So we could do that, but this was also led by the trauma guys, and they really have no interest in continuing this line of research. But with that said, we now have Dr. Burks, who's a big engineer with biomechanical things, so it's a maybe.
But clinically, that's what you would do. If you're going to put a 2.7 plate on, you're typically going to do 4 above, 4 below. If you put a 3.5 for a transverse fracture, if you're in a 3.5 plate, you can do 3 above, 3 below. So it mimics what we would do in clinical practice if you use a 2.7 versus 3.5 plate.
Yeah, I mean, this is not real bone, real healing. This is just extra holes to make it different. Even the 2.7 is better, had less holes.
Where did they all fail?
Furthest out for all of them.
So they all failed at the same place also. And so we don't think that adding more holes will make them fail in a different pattern. They'll just continue to fail through one hole.
Yes.
Yes, but we didn't do it.
Yeah. I guess from my experience, if I was a contact athlete, looking at the refracture rate just following it, I would not want mine taken out. But that is based on a complete anecdote. I will.
Yeah, I
Defer to
mean,
you.
I think your point is if you leave the plate in, they're more likely to fail at the end of the plate. And for that reason, a lot of surgeons want to take them out routinely. And so like what Devin quoted is the refracture rate is actually higher if you take the plate out, and it's because of the holes that are left behind. So this line of research was seeing whether or not the thought that putting a smaller plate in decreases the refracture risk. Putting a smaller plate in? I don't know the answer to that.
There we go.
There you go.
There's the next one.
So many unanswered questions.
Is there data behind that too, or is that just kind of a thought right now?
Dr. Vaughn, what do you do for your hockey players? Those of you that don't know, Dr. Vaughn is the hockey doctor, hockey hand doctor. Also inmates. Great, thank you very much. Thanks, Devin. Michaela? So next, Michaela's going to present her research. So one of the requirements of an ACGME fellowship is that the fellow participate in research. So we identify the project early in the year for the research fellow, and then they work on it throughout the year. And so this year, this is Michaela's project. She'll tell you a bit about it. She did just present this last weekend at the Hand and Upper Extremity Summit at the Greenbrier, and actually won. What place did you win? First place. First place. And I would like to point out they had fellows there from Carolinas Medical Center, UVA, where else? Wake Forest, Duke. Yeah. So just so everybody knows, she's big time.
Just have to All right. So this project, we were looking at the long-term outcomes and survivorship of the Stablex hemiarthroplasty implant that used to be used here. And we'll tell you why. I don't have any disclosures. So the goal of this study was to investigate the non-revision survival of the CMC arthroplasty, specifically the Stablex implant. Why do people even consider using implant arthroplasties for CMC? Theoretical advantages are that it restores the height of the thumb, which will give you better key pinch and grip strength. With that, you'll also have some better hand function and a faster return to work. When did the Stablex implant come about? It was initially introduced back in 2013. The first implant arthroplasties came about back in the 1970s, and those were our initial silicone arthroplasties. but thus far, every iteration of arthroplasty has had too high of a revision rate for it to stay on the market and compete against our more standard arthroplasties. What was the impetus for designing the Stablex? They found that when they were doing total arthroplasties, meaning replacing both sides of the joint, that the trapezial fixation was remaining the biggest challenge and they were having more complications on that side. So they decided to design a hemi, meaning they're only replacing one half of the joint. The design here was a cobalt chrome saddle-shaped hemi-arthroplasty. It was a press-fit insert and it has a titanium plasma spray coating. So the largest and one of the only published studies on the Stablex implant that we were able to find is by Flores and Rubio. It is important to note that Rubio is on the dime of Skeletal Dynamics, which designs this implant. And that's just important to keep in mind because people who own an implant tend to like it to do well. So this study followed 120 procedures. Of their 120, only 2 of them had revisions, but of those 120, they only followed 12 of those patients for 24 months. Those 12 patients that they followed for 2 years did exceptionally well. And that's just demonstrated by looking at their pain scale. Their quick dash function score is only a 2. They had great grip strength and pinch strength compared to their contralateral hand, and they were able to maintain that trapezial height, which is what we talked about at the beginning. Why do we like implant arthroplasty? Because it gives you that height, which helps maintain function and strength. So what was our study design? We looked at all CMC arthroplasties utilizing that CPT code that were collected between February of 2013 and October of 2023. That led to 631 patients that the research team contacted. Of those, 287 patients responded. We did exclude patients who underwent the suture suspension arthroplasty. They were excluded because this institution has previously looked at the outcomes with suture suspension arthroplasty, and that had too high of a revision rate, so that was discontinued in this practice. So looking at our patient demographics, what you'll note is that, as anticipated, there are more women in both the Stablex and non-Stablex groups because women tend to be more impacted by CMC arthritis, but there was a higher rate of men in the Stablex group. With regards to age, there was no difference in our patients. The Eaton score is what we utilize to try and grade the severity of patient CMC arthroplasty. There was no significant difference in the significance of arthritis between those 2 patient groups, and the quick dash scores were non-significant as well. So this multivariable logistic regression that we have here, I put 2 boxes around the most important things to take away. So we looked at several different entities to see if that would impact the non-survivorship of the Stablex implant. Patient's age, their sex, the severity of their arthritis, what surgeon did their procedure did not impact whether that CMC arthroplasty, the Stablex, survived. What mattered most was if they had a Stablex in comparison to one of our alternative methods, or if they were an everyday smoker. So if they had a Stablex in comparison to our other arthroplasties, they were at a 52 odds ratio of that implant not surviving, meaning having another procedure to take that out. And then if they were an everyday smoker, their odds ratio of non-survivorship was 5. This graph, I think, is probably the most clear on demonstrating our point that the Stablex implant does not last long term. So the top portion, that orange section, is looking at all of our CMC arthroplasties that are not Stablex arthroplasties. And you'll see that of those 234 patients, only 10 of them had revisions. But that blue section are patients who underwent the Stablex, and of those 53 patients, 18 of them underwent revisions. And you can see the drop-off happens pretty quickly. So even if you just look at that, 365 days, our year mark, almost 25% of them are not making it to a year. We then looked at patient satisfaction with their care. For patients who underwent a Stablex arthroplasty, you can see they have a much more red and orange section indicating that they were unhappy with their care in comparison to the non-Stablex. We tried to see if there was any association with the generation of Stablex implant, meaning that as they've made newer versions, did that Stablex get better? Did those survive? The answer is that did not change. And then we looked to see if the revision rates over our time of utilizing this implant changed, suggesting that maybe our surgeons at the beginning weren't as good at implanting it, but we learned and got better over time. And doing more of these procedures did not make this Stablex implant last longer. So to conclude, if you used a Stablex implant, you are at a 52 odds of needing a revision compared to all of our other types of CMC arthroplasty. Patients overall were less satisfied with their surgical care if they had a Stablex, despite the fact that ultimately their quick dash was the same. The only other thing that impacted CMC arthroplasty non-survivorship was being an everyday smoker, and there was no effect of which surgeon did it, patient demographics, or how significant their arthritis was.
Thank you very much. Any questions for Michaela? Dr. Hagan?
We did not look into that level of detail of that. Yes. The ingrowth is top notch. No. Sharp.
Dr. Bravo?
Was, with the failure rate, as it kind of progressed, were you guys able to discern at the time, was it loosening, pain, that, were we able to see were there specific different failure modes or just, they were just not doing well because of general? I don't know. I mean, were you guys able to, because I know you have taken, they're not usually loose. They're usually well faced. And usually is an intention mechanism that tends to lead to that you take advantage of the way. Because it is not a total joint injury, it's hard to place. So, and I've taken enough of these that most of them have been for mechanical issues. So another substance is the trapezium just kind of collapses. So I've seen those.
No, for the decision to undergo a revision was exclusively between patient and physician, and that was not something we were able to delve in further besides that conversation was made jointly.
I think that's why she won the award. Great.
There you go.
They're all.
Yeah, I just decided to lump it. I'm not doing opportunity presented, declined. Yeah, no, that's okay. Go for it. There we go. I don't know if you guys got yes. I'll just keep talking. Yeah, it's okay. I finished that already, most of it already. I know, I've been drinking it. I'm working on my fluids. I don't know if you guys got the invite thing that broke down all the talks. I just decided to combine my two because that's a lot of PowerPoints. It's a lot of talking. We're just going to condense it. So here we go. Yeah. I was like, wow, we're good. So a fellowship year, 2023, 2024. It's me. So this is our fancy photo for everybody. And then I decided to talk about different cases. First, we're going to start with the ever suspicious scaphoid fracture. You need to always beware. It's lurking around corners. Hence why we got jackknives. So this, is there a way I can like pull up my notes too when I show it? No? Great. I will try and remember what all these patients were. So this was a young 16-year-old male who fell in the spring and was diagnosed with a contralateral scaphoid fracture, but that initial x-ray was negative. And so he never got followed up again for this wrist, but he kept having problems with this left side. So by the time he got to us, he was like 7 months past where his injury was, and we got another set of x-rays, and it turns out this poor gentleman had bilateral scaphoid fractures. Upside, the one that they did diagnose and cast and treat healed. This one that was not found was therefore not treated and went on to this non-union. And then is there a way to play my videos, or I'll just see. Yeah, I can do it this way. Yep, we'll go there. And so this is a CAT scan that we got preoperatively, just showing the cystic changes in that scaphoid and the chronicity of his non-union. And you'll see he has that humpback. And what I mean with that humpback deformity, it's here where you'll see that it's tilted. Instead of looking like a nut, it's fallen forward. Sad days. So what do? We fix that bugger. And here, our favorite place to go for new bone is the iliac crest, which, as everybody who has met some of our patients, if you take it from the iliac crest, their wrist doesn't hurt so bad, but their hip does. The nice thing is that the iliac crest does have, it's the best autograft bone that we have. And so this kiddo, we harvested from his crest, transplanted it here, and you can, if I kind of highlight, you can kind of see where that, and this would have been where his graft went. And the biggest thing when you're doing your scaphoid non-unions is it gets a little nerve-wracking because that's not, I mean, the x-ray makes this look like it's a substantial bone, but it's actually super small when you get in there. And then you have the key to the non-union, and what has been hammered home this year is how important it is to just keep taking away bone until you get to bleeding healthy bone. Because if you don't do that, you don't solve the non-union problem, and you're at a risk that it's never going to heal again. But as you're taking away a lot of bone and a very small bone, it gets a little nerve-wracking, and then that graft can get quite large for a tiny space, which is quite impressive. But this kiddo, thankfully, decided to heal for us, and just a couple weeks ago, got his follow-up CAT scan. And you can see that he has significant bony bridging coming all the way around, which is what you want to see. This kid has healed his scaphoid fracture. So always be, as Gru, always be suspicious. Look out for hidden things, that average wrist pain that never goes away. Maybe get another x-ray. You don't want to miss a scaphoid, because that is a disaster problem for a young human being. And sometimes we get lucky when we do these non-union surgeries that they decide to heal, but sometimes even when we throw the best bone we have at it, they don't. This is a disappointing case, frustrating. This gentleman, Dr. Bravo is very familiar with. This poor guy is a 61-year-old gentleman who has obviously, as you can see on his x-ray, had just a few surgeries on his shoulder And despite our best efforts at explaining the significance of his situation, does not quite understand that he has a bad problem and is not that old. And I think this case was great at demonstrating that sometimes you will have a patient where the gift just keeps on giving. So this patient had a surgery. You're looking at these x-rays. Literally 4 days before these x-rays is when he had his surgery. And if you're looking at that top right over there where you're like, wow, that cup looks like it's not over the ball, 4 days before this it was. But he came into clinic 4 days later and he is now dislocated. And this is a terrible problem because every time you go into a joint, you're exposing it to infection. And the worst thing that can happen to a total joint with all this metal is getting an infection because they are a bear to try and get rid of. Very sad day. What do we do? So this was a case I had never even heard about. But as we have all found out, Dr. Bravo reads a lot of articles from countries all over the world, and sometimes he throws out ideas. Yes, yes. Right, that's it. Just keep trying, keep trying. So for this gentleman, this is an Achilles graft. And so what you can kind of see on these pictures is there's a button there. And so we've drilled through the glenoid. We pulled those sutures through over a button to secure it to the front part of the shoulder. And then we wrapped that graft around his humeral stem and then tied it over. So it's almost like we made like a cape around the glenoid and its component to try and hold him into position and really hope that that bugger scars in so he stops dislocating. And that's just kind of the end result. So you can see that this center section here is all that graft that's been wrapped around. So you can't see his metal implants anymore because it's been covered with that Achilles. And that was just kind of showing that, like, still you give him an motion, we're just trying to restrict his ability to leave. And so on his most recent x-rays, which were just this last week, he's still located. So thus far, so good. We'll see. But again, I think this case was very much one of those you like are really proud of doing a hard revision case, and then you realize you're just starting the hill. We've got a lot. I mean, he's only 61. We have a long way to go. If there is one thing that you will learn in clinic here, especially brachial plexus clinic, it is the details that matter the most. The physical exam and watching the patients, especially those kiddos, like you can really learn a lot if you just pay attention to their movement. Like the history is important, but sometimes patients struggle to express what they're trying to, like what they've been experiencing. So just listen and pay attention. And if you haven't seen this TV show, it really is great. You should all watch it. It's Reacher, yeah. So this is a 22-year-old who back in August was involved in an MVC and as a result had a traumatic brachial plexus injury. And prior to coming here, we did not, like my orthopedic residency, we didn't do any of these. Like the brachial plexus, we saw them in the pediatric clinic, like birth palsies, but never dealt with any of the adults. I couldn't tell you for sure where they went, but they didn't come to our clinic. So here is really the year where I've learned a lot more about like nerve surgery and what our options are and how to be creative with what nerves you have left. And for this girl, sometimes people say wait, just like wait, see what recovers, keep waiting, see what recovers. But if you wait too long, then you miss your window. And so this girl ultimately went to surgery at 4.5 months after her injury, which at a lot of other places would be considered rather early. But something that has become more evident here is that, I mean, if we don't do something and we miss it, you'll regret it. But, like, if there's a nerve that's not working well, it's probably not going to recover to 100% anyway. So helping it out and giving them function earlier, there's not a downside to that. So on her exam, I mean, for people who are in clinic, you get the privilege of seeing these filled out all the time. But she had no function of her supraspinatus. She had no function of her deltoid, and she had a pretty weak biceps. And if you can't move your shoulder, you can't get your arm into space. And that's a big deal for patients. If your hand works great here, but you can't get it out to where you can put it somewhere, like, that's not that helpful for you. And so this is just a picture of one of her EMGs. Like anything, things that are in red are not good. So she has a pretty devastating injury to that shoulder. And so what she ultimately underwent is we explored that brachial plexus and then explored all of her nerves, all the divisions, and did a spinal accessory to suprascapular nerve transfer, which is one of the more common transfers. But also, like, during these cases, like, you get the EMG, you get their exam, but we're able to actually test each individual nerve during the surgery. And so sometimes, as like Dr. Apel says, like, the EMG is a microscopic sample at one point in time. So you're getting that sometimes weeks before we actually go in there. Nerves change, the history's changing, it's trying to heal. And so having those abilities to test is pretty important, because then you can make that combined decision of, is this nerve showing enough difference over the last EMG to now where I can leave it and have like some faith that it's going to heal? Or is it struggling along and we're going to help it out by doing a transfer or neurolysis? So brachial plexus, you're always going on an adventure. These are long stories. They are long recoveries. These are patients that you have bought most of the time for their lifetime. You're going to help them get a functional arm, but the odds are it's not going to be a normal arm. So you're trying to work together with your patient to figure out, what do they want to do? What do they need to do? And can we make that happen? And then, so this is a picture from when Dr. Apel and I went to Guatemala. Yes, there we were. So when I was applying for fellowships, one of the biggest things that I was looking for in a fellowship was the ability to go on a mission trip. For me personally, I've gone on several mission trips before this, in residency, I went to Honduras. In medical school, I went to Guatemala as well. Before I was in medical school, I went to Kenya. I think it's something that's super important. One of the things I like about doing medical mission trips is, unsurprisingly, I feel like sometimes in the US, we get very coddled with the fact that we can request anything. You might not get it, but you can request anything. And we get used to, in our ORs, having what we want, when we want it, how we want it. And then you get to go to another country where you're seeing problems that people would never live with in the US. And then you're there and you're like, wow, this is a huge problem. And I don't have a lot of the things that I would really like if I was back home. So it makes you be more creative. It makes you think about, what do you actually need to do your job? Because I feel like a lot of times we just do things out of convenience. It's simpler for us. It's easy. But that is why I like going on these mission trips. One, I think you can make a huge difference. And two, I think it makes you a better doctor. So when we were down there was this little girl, she's 5 years old. She has bilateral radial longitudinal deficiency. And that kind of comes in a huge spectrum of what that means. Whether it's, just having some thumb issues, whether they have part of their radius, whether they have none of their radius. For this little girl, hers is pretty significant. Back in 2020, When the Carillion team was there, she underwent a left-sided procedure. And what the pollicization means is essentially they took what was her index finger and swung it over to make a thumb. And now she's coming back 4 years later to talk about her other side. And these are just pictures of that left side for her, showing that she's now able to like color, draw, use that hand. Whereas before, if you can see on that right hand, like this is her thumb. Like there's nothing she's going to be able to hold, pinch, anything there. So where she is now is you're looking at what can we do? I'll say, and what has become more evident to me over this year is one, radial longitudinal deficiencies, they're multi-level problems. Those first two pictures are really just showing she has good elbow function. She needs to have good elbow function before we start messing around and moving her fingers in her hand. And then two, you're looking at the fingers that she does have. So I can talk to mom and dad about how is this thumb gonna work, or this index finger gonna work as a thumb. And the best thumb comes from the best index finger. So this little girl does not have the best index finger. And so that just kind of helps guide where you're like, we're going to reposition it in space, but you know, it's never going to be normal, but it's going to help her do more because it's going to give her something to oppose with. And I think pollicizations, like, and these are her x-rays. So you can see like that little thumb there, that remnant that she has, there's no joint it's even articulating on. Like we can't keep that. And these are some of her intra-op pictures. What I think is pretty cool about pollicizations and different congenital deformities is a lot of it's more of an art where you're not working with perfect and you're not ending it perfect. And you're trying to use what the child has provided you and reimagine in your brain what you can make it look like, and then try and make that a reality. Because you're taking muscles that weren't aligned to do the job we're now going to make them do. And so I think, I mean, especially down in Guatemala, like this is a huge life-changing procedure for this little girl. She can get a thumb out there and have something to work with. And like we were able to do that in Guatemala. We didn't even know if that, like, you know, kind of if like this kid's going to show up because she's been coming for a couple of years, but you still don't know everything that you're going to need. You still don't know what you have. And yet, like, you can do really incredible things if you're just patient, think about what you actually need to get the job done. This is my end slide. So as everyone knows, medical training's long, goes on for a while. I feel like at the beginning, I started like the young Jumanji, a little doughy-eyed. Then you go through residency and training and you end up Robin Williams style. And a lot of things have happened and you're like, wow, what year is it? It's tough. And then you come into your fellowship year and they start asking you, like, what do you want to do? What do you want to learn? What kind of a doctor do you actually want to be? It's a little magical. And then we're here. And the year's over. And it's crazy. Yeah, that's what I have. Is this like question time now? I don't know.
Really, it makes us what we do and work in the late nights, getting down to get to the end of the year. It really does make really what we do really, really exciting and keeps us going. But thank you, because this year's been great. You've definitely been a trooper. I don't know how you juggle so many things.
I stressed Bravo out a lot this year. All right. Okay. Yeah. Well, I mean, one of what I did learn to speak a little bit slower down here when people come in from Franklin County. Talked way too fast for them. But no, I mean, the biggest things are, I mean, what like I was ortho trained, which I know not all the like prior fellows have been. So like what that means is like my training wise, we dealt really heavy like bone and trauma, like that's what Minnesota has. And so, like Dr. Capito, with our soft tissue coverage, going through those things, like that was not something I was really exposed to at all before. You know, my only like experience with that was because some of my good friends were plastics people, so I would jump in cases with them occasionally. So, like learning about different soft tissue coverage and making it simple, because I think a lot of times, like orthopods, you hear soft tissue coverage and like tissue rearrangement, and you go, okay, I'll I'll phone a friend. But you know, you come here and this team works as a team and like they're each teaching each other those skills because it's skills that we have as surgeons, but it's just not a way I was trained to think about. So I think getting that exposure to some of those soft tissues, like I'm not going to tell you I can do a free flap because I can't do a free flap, but there are some now like local soft tissue things that I feel more comfortable about doing. And that way I can keep my patient in my office and help like shorten their visits with other doctors. And I think the other big takeaway for me, and I kind of alluded to it with the one patient, is that we really did not do a lot of nerve work in my residency at all. You know, we talked about it in journal club, but those were just not patients that my staff took care of very often. You know, it either went to our plastics or our neurosurgery colleagues. And then when you're here, we always like, we operate and we always go and find the nerves and we always go and find the blood vessels. Like you go find the things that people are afraid to find first. And if you find those, then everything else you know you can touch and like go do what you need to do there. And getting used to finding those things, the more you do it, the easier it is to find them. And the better your understanding of anatomy is, I think the more you can do as a surgeon. And so now, like some of those nerve transfers, like, no offense, the brachial plexus is just not going to be where I live in the future. But, but some of those distal nerve transfers, like especially when you're talking like distal arm down, like those are nerve transfers where you're like, I already operate there all the time. That is anatomy that I now am much more comfortable with. And so being exposed to that now, I'm like, those are services that I can offer that I previously was like kind of a black box question mark, like knew it existed, but didn't quite know what that meant. So those are the two biggest things for me.
Helps us stay in touch with fellows, get a sense whether or not we can.
I just bribe everybody. Yeah. Got morbid there. There we go.